Good day everyone, I am Sofia Michibi Ayay and for today we're going to perform a skin flap and graft technique. So here are the following equipments. The patient must be under general anesthesia and carefully position it to free up any available skin in the region. Aseptic techniques must then be applied. Here we are doing a subdermal plexus flap, specifically the rotation flap. So a curved incision is begun at the point of adjacent to the shortest side of the triangular wound. So the incision is gradually lengthened and the flap undermined until it is sufficient length to cover the wound without tension. Here we are removing epithelialized portion of the granulation bed by sharp dissection, followed by undermining the skin attachment to free up the bordering skin. Next is to measure and transfer the skin flap to the defect. Flaps can be transposed at an angle greater than 90 degrees, although the flap length will shorten with this greater arc of rotation. Undermine the skin at least 1 to 2 centimeters beyond the defect. The use of a 4-0 monofilament non-absorbable suture material is placed in a simple interrupted pattern to close the skin. According to Saunders, we can also use skin staples. So upon using a surgical staples, this will serve as a stay suture or fine skin hooks when elevating the flap to avoid causing excessive damage on the skin. Here is the finished product of our rotation flap. Next, we have the L-plasty, or also known as the O2L advancement flap. It is a single tangent flap where the incision is made at one end of the defect. Here I am removing epithelialized portion of the granulation bed, creating an O shape. Note that it is better to create two adjacent short flaps rather than one long flap, which have greater risk of necrosis from inadequate blood supply. Here we are incising the pre-planned donor skin margins. So the mobilized tissue is then advanced to the defect. So of course, don't forget to undermine. As noted, the length of the flap should be kept to the minimum in order to close the wound without excessive tension. The primary problem associated with advancement flaps is their reliance on stretching over the wound. There is a tendency for elastic retraction by collagen fibers in the flap's dermis. Here we are locking the flap using surgical staples, hence the use of a large 2-0 monofilament non-absorbable suture material will be helpful to tack, especially in the skin of the limbs up to the thoracic wall. Next, we have mesh skin graft. So, aseptically prepare the donor and recipient sites. We are doing infiltration anesthesia. So, estimate the size of the wound by measuring or cutting out a template using a sterile drape material. So, after that, we are sharply excise the donor skin from an area of thin and redundant skin. So, avoid excising the subcutaneous tissues. So, lavage the skin frequently with sterile saline. Here we have the recipient. Make a multiple full thickness holes, as you can see, a mesh with 1 to 2 cm in length and 1 to 2 cm to 1 cm apart. Sutures such as simple interrupted crochet or simple continuous or skin staples are used to fix one edge of the graft to the skin along one edge of the wound. So to ensure an open mesh on the graft for wound drainage, a 2 to 3 millimeters margin of skin is trimmed from the free graft edge before it is sutured or stapled to the remaining wound edge. So after edges are sutured, the graft is further secured by placing simple interrupted sutures between the slits in the graft at strategic points where contact is not firm or motion is likely to occur. Additional sutures are spaced throughout the graft field but not through all adjacent slits. So the skin donor site is undermined and the defect closed by advancement skin edges. In bandaging, a very thin coating of antibiotic ointment is evenly spread over a sterile and adherent absorbent dressing pad. Next graft, we have the pinch or punch skin graft. Gently pick up the skin with thumb forceps or stay suture and excise a 1 mm piece of skin using a number 15 scalpel blade. Alternatively, harvest a punch graft using a 5 mm skin biopsy punch. So place the punch at the same angle as the hair follicle during harvesting. So make sure to avoid subcutaneous tissues and place the skin pinch or punch in a saline moistened surgical container. To place pinch graft in the granulation tissue, small slit-like pockets are made in the granulation tissue almost parallel to the surface of the wound with the openings upward. So the pockets are made 2 to 4 millimeters deep. Be sure that the epithelial side of the pinch is facing out, so repeat this process as many times as necessary and place a non-adherent dressing over the wound. The first bandage is usually changed 3 to 4 days post-operatively. That's all, thank you.